Okay, so we were left off talking about social gradient, the idea that your socioeconomic status has an impact on your health. Right? So socioeconomic status is a agglomeration of all of kind of your identity characteristics, your economic status, how society views you, and so on and so forth. So it is a multifaceted way of kind of talking about where you fit in the hierarchy of society. And what we talked about, people who have who come in as lower in the socioeconomic status hierarchy suffer from more chronic diseases, tend to engage in worse health behaviors, which we talked about way back several chapters ago, right? We talked about health behaviors are things that you have control over, like what you eat, your diet. Is your diet healthy? Right? Do you eat a lot of high-fat foods? Since this is a British study, do you eat a lot of fish and chips? Do you drink a lot of, do you drink a lot of Newcastle or whatever the beer is over there? Do you smoke? Do you get exercise or not? Right? Do you spend all your time watching TV? And so forth, right? So these are, a lot of these health behaviors are negative health behaviors are associated with lower socioeconomic status. Some of that comes about because people lower in socioeconomic status tend to be poor, right? Like that's a part of your wealth is a part of your socioeconomic status. And poor people tend to live in environments where it's hard to get exercise, where, to go outside and walk around. They tend to live in areas where there's a lot of fast food. Right? And then they tend to be around other people who are doing similar things. We tend to self-segregate, right? You think about a wealthy neighborhood and a poor neighborhood, typically in your hometown. The people who live in a particular neighborhood tend to have the same general level of wealth and socioeconomic status. We self-segregate. So socioeconomic status is a broad measure. In the United States, we spend a lot of time talking about race. Race can be, in the United States in particular, race can be a substitute for socioeconomic status. But my point in showing you this is, it is a highly imperfect measure of socioeconomic status. Right? You can have very poor white people, right, on the far left side, who have very poor health in general. You can have very wealthy Black people who, on average, tend to have access to high quality care, high quality food, good neighborhoods, and so on, right? And so race is less an effective, it is a imperfect, and sometimes, in my mind, distracting measure of socioeconomic status. So it's more effective to think more broadly about an individual, and this is kind of my theme, is coming back to the individual, right? And not just focusing on groups. So socioeconomic status is a useful lens to see the world, to think about, and to understand that there are negative health impacts associated with, correlated with socioeconomic status. But you can be poor and be healthy, right? You can make good choices. You can cook at home instead of eating at McDonald's. You can, still get exercise. It just might be harder to do. The problem that, I asked you to listen to my briefing about my food desert experiment way back. We were just joking before class about how the semester seems like, looking back at what we did at the beginning of the semester is like forever ago, right? But one of the things that I've observed and I've talked about a lot is being poor is this really awful multi-dimensional problem that you have to solve. Like if you've only got so much money, you can pay the rent, buy good food, pay for a babysitter, right? But you have a real problem to solve. And the happiness literature, if you go look at the happiness literature, it used to be said that if you earned at least $75,000, additional money wouldn't really make you all that much more happy. More recent literature says actually that's not true. More money still makes people more happy. Right? You are happier with more money, even past that kind of $75,000 threshold. And the reason is because having more money gives you more freedom. It gives you more capabilities, right? I've talked about, I'll mark this a bunch of times, you guys talking about your doings and beings, right? This idea of, if I have more money, I have more choices. I don't have to, if I have lots of money, if I'm on the right side of this graphic, right, in the fourth or fifth quintile of pretty much any of those lines, I have a lot of choice. I don't have to choose between, do I want to pay the rent or pay my car payment? Right. But if I'm on the left side, regardless of which line I'm on, I'm probably making some hard choices day in, day out. So what I was saying, coming back to this happiness literature, what they've shown is people who have more money they don't have to make choices between things like, can I take this job? And if I take this job, I can't afford healthcare, or I can't move close enough because I can't afford to live in a town that's close to my job, right? But if I have to commute an hour and a half each day, that's 3 hours more childcare that I have to get. And so wealthy people don't have to make those kinds of trade-offs in their lives. They just do, right? They don't have to think about it. And so socioeconomic status has a huge impact on our lives and our choice sets. So going back to the doings and beings, right? If you're wealthy, you have capabilities that give you freedom to make choices, to live the life you want to live. If you are lower socioeconomic status, you have fewer choices. So I want to talk about culturally competent healthcare. So if we have special populations, if we have different populations that we are trying to care for in our healthcare system, for those of you who are future providers or future administrators, thinking about how do I care for these populations? My sister-in-law teaches in the Concord school system, and in the elementary school, and she sometimes has little kids with 4 or 5 different languages. They're coming from households that speak 4 or 5 different languages, and she's a second grade teacher. So she's working with kids who are learning English as a second language, and then working with parents who maybe, again, English is not their first language either, obviously. And so she has to be aware of the cultural, so being culturally competent, she has to be aware of the cultural mores, the cultural beliefs and traditions of the families of the children that she's teaching, so that she can understand them and take better care of them. And so likewise in healthcare, if you're working in a city, right, we tend to think of New Hampshire as this like homogenous blob of white people, but that's really not true. Right? So first of all, we do have something like 95% white, right? And I use that with scare quotes, 95% white people in New Hampshire, but we have a wide range of socioeconomic statuses, right? We have a wide range of cultures. So if you just look at skin color, you'd say, well, it's homogenous, they're all the same people. Really, really not true. If you travel up to Berlin, if you travel up to Gorham, right, people up there have a different culture. It's not radically different. It's not like you travel to China or something, but it is different. They have different beliefs about what's important in life, right, than people who live in Manchester, regardless of the color of their skin. And so you have to be aware of, if you're a provider or you're building a provider system, or you're concerned about a healthcare system, you have to be aware that that the people who present to you have come from different backgrounds and have different life experiences. And so But if you are in particular in a place like Manchester, that is a huge melting pot of different cultures, right? Manchester takes in lots of refugees. It's a wonderful thing. But if you're a provider and you're meeting a new patient for the first time, and this person maybe doesn't speak English as a first language, how are you going to communicate with them effectively to make sure that they're understanding what you're trying to explain to them? Because physicians, kind of forget sometimes that they're talking in medicalese, right? This, special language that they all understand and talk, to their colleagues with, and they sometimes forget that they have to dumb it down for the rest of us to, be able for us to understand what they're actually talking about. And good physicians keep that, they're good at that. But if you then add on a layer of, I'm not a native English speaker, and maybe I come from with a different culture where medical professionals are not as trusted. And that could be, by the way, in the United States, right? There are minority populations in the United States that don't trust healthcare providers, and with good reason. Right? We have the Tuskegee syphilis experiment, which I think we're going to be talking about later, which involved a large number of Black men in the, I want to say in the 30s, started in the 30s. I've got to refresh on this, but I'm going to get the dates around right. In the 1930s, a group of Black men presented to public health service, US public health service hospitals with syphilis, which is a sexually transmitted disease that has devastating effects, right? It can cause mental illness. It can cause a whole series of really bad effects. And the medical profession decided to create an experiment where they didn't treat a large proportion of these men, these Black men. And they didn't tell them that they were part of an experiment, and they just tracked them to see the progress of the disease. They had treatments at the time. They could have treated them to some degree. And as the years passed, they could have treated them. And more people came down with syphilis, and they added them to the experiment. And this experiment went into the 90s. I want to say 80s, 90s, somewhere around there. It went for about 50 years. It went for a long, long time. And it was run by the US government. So many of these men died of complications from syphilis. And if you don't treat a sexually transmitted disease, what happens? It gets spread around in the community, right? So when you talk to these populations, right, and you talk to a population that's aware that the medical profession did this to people that look like them, then you wind up with a lack of trust. And there's other examples, but that's perhaps one of the most glaring ones. And it took years of having that be outed. People, there were whistleblowers that eventually said, hey, we're doing this, what the hell are we doing? We're a medical profession, we're supposed to take care of people, not let them live with the disease when we can cure it, right? That's really an awful, terrible thing. And so if you treat people like that as populations, they resent that and they don't trust you. So you have to bear that in mind when you're a medical professional. So if you have people coming from foreign countries, right, they have different beliefs about how they should be touched, right, how they should dress, whether a male doctor can see a woman, or a woman can, or a female doctor can see a man, right? Those, like this cross-gender treatment, is that acceptable? That's a thing that is a real concern. Now, being culturally competent requires that you try to be aware of the cultural concerns of your patients and of your patient population. Obviously, you can't get this 100% right, because if somebody shows up from a culture you've never seen before, you just want to try to do the best you can to understand their concerns, to understand their culture. Now, being culturally competent doesn't mean that you use the methods and the treatments that the foreign culture, you don't necessarily use the treatments that the foreign culture uses. you still use the right, the right treatment. Based on you use the right treatments based on evidence-based medicine in the United States, but you want to, let me see if I can stand sort of here. You want to, Barb should be joining us in a minute now. You want to make sure that the patient understands why you're doing what you're doing. Let's going back to that illness versus disease discussion that we've been having, over the whole semester. It comes back. The reason I present that to you early on is because it's such an important idea, right? Culture influences your beliefs about your own health. So that's the illness component. So if you, so people from a different culture will have a different sense of what illness is. And then they're presenting here to medical professionals who are going to decide on whether they have a disease or not, right? And so we're trying to navigate between those two things. See Barb coming. All right. Maybe I'll go back to slides. Let me minimize that for a second. So there are these things called class standards, culturally and linguistically appropriate services. There's some guidelines for providers. So if you're working in a healthcare system, you're going to want to have these concepts in place for your providers and help them understand what they have to do. So the idea is to have these guidelines that recognize that one size does not fit all. So we might have cultures within our country, and I've talked about like living in Louisiana, right, is a different experience than living in New Hampshire. There are cultural differences there. There are cultural differences across racial and ethnic groups, that beliefs about what's appropriate and not appropriate. Religious groups, what's appropriate and not appropriate. So the important thing is the bottom line here is to ask the patient about the cultural components that the patient wants to integrate into their care. And they'll tell you. Oh, there we go. Hey, Barb.
Hello.
I was going to move you over here so they can see you.
I like your topic. That's a very excellent point.
All right. Is that relevant to our conversation today?
Well, I think it's relevant to any conversation with any patients. I think people feel dehumanized often in the healthcare system. And if you can humanize it in some way by treating them as human beings and not a diagnosis, I think it goes a long, long way.
Yeah. All right. Well, hey, I already told them you were coming. So welcome.
All right.
Of the Krempel Center. Barb, maybe, and so we're talking about special populations, as we talked about on the phone yesterday. So we're going to be talking about the Krempel Center and brain injury as a special population. We talked about, so maybe talk a little bit about yourself and how you, your background and how you got to be working at the Krempel Center.
All right, great. Thank you so much for having me. We really appreciate it. Brain injury and occupational therapy are both, huge passions of mine, and Krempel Center is, just an amazing place. So I love the opportunity to talk about it. So thank you. I am an occupational therapist. I actually was a career changer in my late 20s. I was working in international business and realized that wasn't wasn't making my world. It just wasn't doing it for me. Honestly, I had an experience where I had an opportunity to help somebody in some very small way. And it was that literally that moment. I was like, that's it. I'm switching careers. I got to find something that's going to be more fulfilling to me. So that's that. I mean, I can literally pinpoint the moment that happened. So I say, follow those instincts, folks. It's a really, you want to do something that's fulfilling. So I'm an occupational therapist, and I understand you have maybe at least a few in your class. It's a great profession. For those of you who may not be familiar with it, we really help people to live the lives that they want to live, either by helping to helping them to build skills that they have lost for some reason, and or working around those problem areas and teaching strategies and ways to compensate, or a new way of doing things. So it's very, very fulfilling. So as an OT, I think I'm very, very aware of who is this person and what is important to them. So that's why I particularly liked your talk there. And I think one of the things that it really makes me think of is that we as human beings, when we encounter other cultures, and this really does relate to brain injury, I think it's our discomfort that prevents us from maybe making other people feel welcome. So I have heard many, many times from people who are living with brain injury, who have a visible disability, that they feel completely invisible, that people avoid eye contact, that they'll walk right by them. And I am absolutely convinced that those aren't horrible people that like have disdain for somebody living with a disability. They're afraid of doing something wrong. So I think asking the question is a really great thing. How can I help you? Do you need help? What's this like for you? So I've been an OT for 30 plus years. I've worked all across the healthcare spectrum. I started my career at the VA hospital, which was fabulous and fun. And oh my goodness, wow, such a different culture. That alone was culture shock and really extremely fun. Those were folks who, honestly, the hospital and the clinics were their second homes. So I really got to know those people. So I've worked everywhere from the ICU all the way into home care. And now I'm even almost sort of beyond home care in a community setting. I've been at Krempel Center for about, I think it's 16 years now. I started as a person working like on the floor, running the program, and then I became program director. And recently decided I wanted a little less responsibility, so I'm doing some consulting work. Brain injury, I had seen folks living with brain injury before, and in our world, we work with people who are living with acquired brain injury, and that means So the idea is that our community does best in serving people who have experienced loss because of their brain injury. That's one of the things that binds people. So they were living life, and something happened, some sort of brain injury or stroke. Stroke we do include in brain injury, and therefore. That's one of the things that kind of binds our members, is this sense of loss and change, which they can really find support with other people. I particularly love brain injury because these are the most complex patients or clients that I've ever worked with. So to me, it makes it very, very interesting. And there's a saying in the brain injury world that if you've met one brain injury survivor, you've met one brain injury survivor, right. Which basically means every single person is very, very different. Because I've been at it for so long, I've seen most things that can be impacted, but not everything. We still can get something incredibly interesting. Kind of diagnostically, but I'm wondering, I was curious about with your class, your students,
Yep.
because I can't quite see people very well. I'm wondering if people can tell me what they think of when they think of brain injury.
Sure. What do you think of when you think of brain injury? Shy. Yeah, Joyce.
Damage to the brain, like the nerves and cells.
Okay, damage to the brain, like nerves.
Yep.
Yes. Yeah.
Well, I think that, like you've already touched on, it can be like a large spectrum of things. So like the way that it affects one individual might not be the same, but like some sort of traumatic event that then leads to like harder processing in the brain, or like maybe in other cases, like inability to do certain daily tasks, things like that.
Can you hear that?
Absolutely. I
Okay.
can. I heard it well. Thank you.
Right here.
I was gonna say, it can also be like damage to the prefrontal cortex. So like a lot of your day-to-day decision making can like change in your personality, but I don't think you would necessarily look at that person and know that they had like a traumatic brain injury.
Oh, what an excellent point. Yes.
I think that it also like can come in different severities. So like it can be as little as like a concussion, or like that gives you brain injury, but like gets better, but it can also be like a stroke where like it's more permanent.
Absolutely. Yeah. So you guys actually have some good basic knowledge there about it. And I think one of the really important things to recognize about brain injury is there may be some visible aspects. Somebody might have some paralysis. Often it's one-sided paralysis or partial paralysis it's either called hemiparesis, which is weakness on one side, or hemiplegia, which is paralysis on one side. And it's actually on the opposite side that the brain was damaged. So if you have a right-sided stroke, you may have some problems on your left side in terms of motor abilities. The other part to think about, and you guys touched on it, is the invisible aspect. I can tell you that I've had, since I've been working in this field, I have met people out, just in the general public where I'm like, I wonder if they have a brain injury. And I think that these are people who struggle out in the world because their injury is invisible, or their challenges are invisible. So they just may come off as kind of odd, or kind of, not able to manage whatever it is they're trying to do. And so I always, I guess for me, working with this population, one of the sort of life lessons that I've learned is that you always have to wonder what somebody's been through, and not just kind of label them as different or odd, or, so just being really, really mindful of that. I love that you mentioned concussion. I bet your peers and people even in your age group, this is a big issue. And concussion, if you just have a concussion, it will go away, but many people live with post-concussive syndrome, and it can be very, very challenging, again, because of the invisible nature of it that people just don't understand. You look fine. Why aren't you, coming out with us tonight? Or why are you suddenly not doing well in your classes? Or why can't you seem to get out of bed? Or why don't you respond to me in text messages? This person may not be able to use their phone, or screens are really bothersome. So at that point, honestly, a concussion is a brain injury. It's just one that will resolve. Since you guys are talking a lot about health systems, I think one of the really important things to understand that I've really become an advocate for is that brain injury is treated almost like, I broke my arm, so I'm going to go get treated. I'm going to go through the rehab that I need to go through, and then I'm done, right? I've got my arm back. Brain injury, unfortunately, in our healthcare system is recognized more as an event than as a lifelong condition. So, and in our experience, people need lifelong different kinds of not only medical intervention and opportunities and services, but they need to have a different eye on them over time. And people living with brain injury, even later in life, they have different needs. They're more likely to develop dementia. There's lots of different things that means when you're living with a brain injury. The challenging part about that is with the healthcare system not recognizing that historically brain injury survivors have been kind of put into one of two systems that are geared for lifelong, considered chronic conditions, kind of lifelong care. One of those is developmental disabilities. And the other one is, does anybody have any thoughts about what the other one might be? A system that's in place for for people that need care all across the spectrum of their lifetime? Any thoughts?
So developmental disability would be someone born with Down
Developmental
syndrome.
disabilities is one.
Okay.
So the other one is mental health. So people with psychological disorders. And what's interesting about that is that I could have a stroke today and be put in with folks with, and have any services that I have for the rest of my life be in and amongst folks living with a developmental disability, which, there certainly may be some similarities to what we're going through, but those would not necessarily be my peers, right? And the same thing with mental health, with folks living with mental health challenges. Folks with brain injury may have co-occurring mental health diagnoses, and people living with brain injuries are more prone to depression and anxiety, but that does not necessarily make somebody living with, lifelong schizophrenia, a peer or somebody that they can relate to or feel or have similar experiences with. So it's just something to think about in terms of, I think your class sounds really interesting. And I think in terms of systems, are all of our systems providing, do we understand the population that we're serving well enough, and are the systems in place? So, which brings me to Krempel Center, which is where I work and where Mark is, Professor Bonica is a board member. And we were started, I should have put, I have a few photos for you in a moment, but we were started actually back in the 1990s, when our founder, David Krempels, had a car accident. He was on the day after his wedding. He was heading up the main turnpike for his honeymoon with his new wife, and they were rear-ended by a tractor trailer that never put on their brakes. And David survived with an extremely severe brain injury. His wife was killed at the scene. So that was the beginning of a really incredibly tough period for David. He was, he was in a coma for a period of time. He had to learn to walk, talk, toilet, eat, everything again. For a lot of folks living with brain injury, they are literally, in terms of their functional abilities, going back to infancy. It goes back to literally, can you toilet and bathe yourself? Can you eat? Can you speak? Can you tell somebody what your basic needs are? For people, for instance, with communication challenges, one of the first things we're trying to do in the hospital setting, and hopefully this will resolve over time a little bit, but is, can we get a reliable yes and no out of somebody? If it's not verbal, can they do a thumbs up, thumbs down? So think about somebody who's a highly functional person reverting back to, really the things that parents are dealing with infants and very young children. So David, had a couple of years of recovery. He had financial hardship. He had loneliness. He had depression and anxiety. He lost many of his roles. Obviously, he lost his role as a spouse. He lost his work role. He had been a very successful high-end contractor owning his own business. So he wasn't making money. The only time that he really, he will tell you that I think it was a hot dog and there was something else. He ate the same lunch every day because it was so that he could just do the same shopping every time that he went. It was something like a hot dog. And I mean, it was just, you know, he literally couldn't handle going to the grocery store and getting more than 5 items. So it was just back down to basics. The one place that he felt like he could be himself and where people understood him was at a support group, a monthly support group for brain injury survivors. And it was offered by the Brain Injury Association of New Hampshire. And over time, as David resumed his life, he was fortunate to have a really good set of friends and family that were supportive of him. He realized that there were a lot of people who never got out and never felt understood and never were amongst their peers, or only the only time they did get to do that was once a month. And that's why he decided to start a center when he did win some money in a lawsuit from, I think, a Maine Transportation Department and the trucking company. And so he had enough money to take care of himself and really, really wanted to do something for brain injury survivors. And that's when when Crimple Center was born. And I'm just going to share my screen just to show you a picture or two of Crimples. Are you there? Can you see Crimple Center with a whole bunch of folks?
Yep.
Okay, so this picture is a picture of our community meeting. So the Crimple Center is a place where it's a community program. We offer groups, up to 15 groups a day that people can attend. I think, and so they can, and those address everything from cognition to physical well-being, to support, psychosocial support, to creativity, to functional skills like cooking and using computers. So kind of it's geared to address anything that brain injury survivors might be going through. So what you're looking at in this picture is our community meeting in the morning where we all come together, and that's where you learn what's going on for the day. So you actually can see some interns here. We've had many UNH interns come through our doors, talking about the group that they're going to be running that day. What's amazing, and then I'll just show you a few pictures of some of the types of groups. So this is a creative group. It's like a paint night kind of thing around the holidays. They're doing I think they're, yeah, snowmen. And then just one more. This is adaptive sports through Northeast Passage, which is also part of UNH. So that's a creativity group, and then a group geared towards physical well-being. We have many more options, lots of, especially cognitive groups, because there are so many cognitive skills. When I'm talking about cognitive skills, what comes to mind for you? Do you know what, you've already touched on a few of them. I think somebody talked about the prefrontal lobe. That's kind of often a behavioral issue. Behavioral issues can happen, and difficulty with social skills. That's another area we really address. Are there any other, what do you think of when you think of cognition? What kind of things could be happening?
Coordination.
Okay, coordination would be more in the physical realm, but it is, you know, coming, but yes, absolutely. Coordination can be a really big issue for people.
So cognitive, what does that mean to you guys?
Memorization,
Memorization,
Yep, memory.
being able to like pay attention.
being able to pay attention.
Oh, yep, absolutely.
I guess just like being able to focus on like the task at hand and like understanding what's going on around you.
Being able
Yes.
to okay.
Almost that's a couple of things. And often cognition is really hard to tease out because it is invisible. So that could be divided attention, right? The ability to have divided attention. or enough concentration, the ability to concentrate, and it also could be working memory, right? So working memory is where you have to hold on to a piece of information and then maybe manipulate that. I'm just trying to think of a quick example of that. You're going to, I'm coming up with a blank, but we use it all the time where you have to hold on to a piece of information while you're doing something else and then incorporate that piece of information in. So any kind of multitasking that, you know, that requires it, any complex task requires it. So maybe like cooking. Think about cooking, how complex, oh my goodness, cooking is an incredibly complex activity. You have to you have to be able to sequence things. You might have to do some problem solving. You have to have safety awareness. You have to have the physical abilities, the coordination potentially. You have to be able to identify objects. You have to be able to have the sensory ability to handle hot, cold, those kinds of things. So it's a very, very complex, you know, you probably didn't think about that before, but it is a really, really complex task for people.
Barb,
So we do, yep.
yeah, I was going to say, I've taught them ADLs and IADLs. So, so we're talking, to me, the IADL is a lot of cognition in that area. Maybe you could use that framework a little bit to tie for them.
Yeah, so ADLs, you know, I think they all have different cognitive, every task has different cognitive demands. Our ADLs are activities of daily living, and they're kind of like your basic, like I said, feeding and bathing and toileting and those getting dressed. And then the IADLs are kind of a bigger picture thing, like being able to shop. They tend to be more complex. So shopping, kind of maintaining your general health, driving. And I don't know if any of you have experienced a concussion, but a lot of that can impact your really high level cognitive skills, such that what we call executive functioning. And it's almost like the computer in your brain that keeps everything organized and enables you to initiate a task, enables you to stay on task. So the milder the brain injury, the more like everybody has probably, almost everybody experiencing a brain injury will have some executive functioning issues. If you have a mild brain injury, it might be the only, you know, maybe your only real cognitive challenge, but it is a bear. You know, as college students, you are really heavily relying on your executive functioning. Yeah. So you think about it as the computer that runs your body, and it gives you commands and tells you what to do. And if that's broken, and really anything is extremely hard to carry out. Those executive function skills certainly impact ADLs, but
it's more of an IADL.
Sometimes the bigger things or other things are going to be more obvious.
But I'm thinking like brain injury tends to be, I mean, certainly severe brain injury is going to impact your ADLs, but the level of brain injury, I'd say the Krempel Center is often more on what you were describing, like challenges to go shopping, challenges to cooking for yourself. So a lot of the things that allow you to live independently, the IADL. So it's more on the IADL side, at least the population that is at Krempel's.
Well, that perhaps that's been your experience, but I would say that we really do have the full spectrum. And historically, Mark, it's very interesting that you're saying that, because historically, our spectrum was more on the severe brain injury side, and many people came with caregivers. Over the years, I think partly because brain injury is becoming a kind of a hot topic. There's a lot of research being done. Concussion has become such a big issue that it's just more in the popular media these days about brain injury, but with football and hockey and those kinds of things, soccer. That I think we have our population we've gotten more milder brain injuries than we used to have. So which is one of our struggles as an organization. And we try to make one of the challenges for our interns who run our groups is to make every group accessible and meaningful to every person who chooses to attend. So that could be somebody who has a very severe brain injury and maybe a caregiver to help them, to somebody who is experiencing post-concussion syndrome and maybe having difficulty returning to work. So that's really challenging. And to me, one of the really, really fun and interesting parts of being an occupational therapist and having our community. The other thing that allows, one of the things we've done some research, our outcomes research that we did a couple of years ago came up with some really interesting results. And that was, we looked at perception of stress, perception of quality of life, and social connectedness. And in all three arenas, our members of Krempel Center, came out as having similar levels of stress, levels of social connectedness, and sense of quality of life to folks who were not living with injuries or disabilities. So a typical population like you or I, or your students. So that's very, very, so that to us, that's a really amazing outcome because if you look at brain injury literature, people are isolated, people deal with a lot of depression and anxiety, people feel like not very hopeful and that life isn't necessarily worth living. And we can see that by offering a community with opportunities to engage, to be with your peers. And in what I was going to say is that mixed community allows our higher functioning members to help some of our folks that might need a little more help, and it gives them a sense of purpose again. So that's been a really cool finding for us, is that mutual, you call it mutual aid, is how can you help each other? And there's a really strong sense of that at Krempel Center, and that has become a very meaningful part of the experience for people. So sometimes you're doing activities that play to your strengths and you might be helping other people, and other times you really need help. It's something you're struggling with, and people might help you. So the idea, yeah.
I was just going to say, I really like that idea, because one of the things we've been talking about is the definition of health, and the WHO. So the traditional kind of medical definition of health is the absence of disease, right? But the WHO definition is it's more than just an absence of disease; it's a sense of well-being. And so what you're describing is, being able to be helpful, having a sense of purpose in your life is an important part of having that sense of well-being, that overall sense of health.
Absolutely. And folks who are, being impacted by brain injury have often lost most of their other roles, right? They may not be able to help at home the way that they did before. They may not be working, so they're not bringing in a salary, and they might have considered them, or they might have been the breadwinner, or, taken a lot of pride in that. They might have been the fix-it-up person at the house and can no longer do that. So offering a community like ours might be the first time they start saying, you know what, I can contribute to the world around me, which is just, you can't overstate the importance of that. The other part that I would say in terms of any health conditions, but certainly ones that are kind of lifelong, like brain injury, is the importance of being around peers. A lot of our members say that they feel more comfortable in our community than they do even at home, because they're as much, and this doesn't mean that their loved ones don't love them and don't try to understand, but there is, what happens is when they come to Krempel Center, we have a lens through which we can look, where we understand brain injury and even the invisible aspects. So for instance, somebody might say a wife gets in touch with us and says, Tom won't do anything anymore. He just sits there and looks at the walls. He's just not motivated at all. Well, is that person really not motivated, or do they have trouble with initiation? Can they not remember what they're supposed to be doing? there's so many things that could be going on. So I think that our members really appreciate that people are looking through a brain injury lens, and that they're around other members where they don't have, what the most interesting thing about them isn't that they have a brain injury. Everybody there has a brain injury. So you now become a human being again, right? Based on other things about you. So I think peer support for this and other health challenges, I think is unbelievably important to think about. So if any of you do end up in healthcare or yourself in need of healthcare, don't underestimate the power of peer support and opportunities to have peers together. So for our members, they really, I think it depends on the person, but a lot of people, the community aspect is more important than, can be in some ways more important than the opportunity for skill building, which a lot of the groups offer skill building opportunities, right? So they're getting a chance to continue their rehab. And most of these folks have been discharged from their medical services. And so imagine that you've been getting a year, you had a brain injury, a year and a half goes by, you're 22 years old, you had a brain injury in college, and suddenly you're nowhere near back to yourself. And everybody says, well, you're not making enough progress, so we're discharging you from all your therapies. And there you are, like, are you kidding me? And meanwhile, your friends have moved on, they're getting their first jobs, they're graduating from college, and you've gotten a lot of attention at the beginning, but everybody's life is moving on and yours isn't, from what it feels like. So that's often when we come into people's lives, is post-rehab. Yes, there are still opportunities for you to make progress and to continue to work on this. So it's been a very, very important part of our program for people to go, okay, I'm not done. I'm not supposed to be done. I have ways that I can continue to work towards my goals.
Right. Last week, we were talking about long-term care and community-based supports, and kind of the idea that what you just described is, you have initial injury, you're treated in acute care, you might go through inpatient rehab. And then a condition like this and then what? Which is what David ran into, right? And so Krempels is just this great example of community-based services that provide long-term rehabilitation and development.
Yeah, and I think it's one of the important distinctions that we have made is when you come to Krempel Center, it does not feel in any way, shape, or form like a medical facility. We don't even ask the usual questions. We don't have charts on people. I forget for many of our members how they even got their brain injury. It doesn't really matter. It's just, who are you in this moment? And so one of the things that the medical world is interested in what's wrong and trying to fix it, right? Which is great. It's very necessary part of the process. But ultimately, once you want to get out there and live your life, a strengths-based approach is really important. Here's what you want to do. Here's the strengths you're bringing to it. Is there a way you can use your strengths to accomplish that while we work on the other areas? So we are not focused on what's wrong with you. We're focused on what's right with you and what you want to get out of life. And that's a big difference. And actually, hopefully that ideally, in my mind, should start during the rehab process, right? And it does, but you're still often in a facility that's a medical facility, and you probably still have medical issues going on. So we try to feel really different from that and try to approach things differently. So you're not going to go through a huge, we don't care about all your charts and your this and that, that's not important. We're about, who are you and what do you want to get out of life? So, yeah.
Well, hey, Barb, thank you so much for joining us this morning.
You are so welcome.
And I encourage you guys, Krempels does a fireside chat, which is an opportunity for non-members to kind of check out the program and see you know, and learn a little more about the organization. So maybe if, I don't know when do you know when our next one is?
I don't know that, but I will also say, if any of you are, you know, interested in pursuing health professions or learning more, we have, you know, lots of opportunities for internships or volunteer stints. And we do ask that you're, I think, junior year or beyond, but really phenomenal opportunities for internships even during the summer. And like I said, internship would mean that you're getting credit doing it through school, but about lots of people come and do, you know, a 8-week volunteer stint with us. So keep it in mind. It's a wonderful place. It will change your life. There's no doubt about it.
All right. Hey, thank you so much for your time. I appreciate it.
Thank you. Thanks so much, guys.
All right. Take care. Just get reset. I can't find my- So what'd you think? Ready to all be OTs now? It's a great field. What I really love what she talked about at the end, about the purpose of that care is to take the person, the individual person where they're at, right, and say, what is it you want to do? You know, yes, you've had this traumatic injury, you've had this life-changing event, but what is it that you want to do with what's left of your life and with the capabilities we can restore to you? What do you want to do with that? What would give you meaning so that we can kind of help move you forward? And that's the driving philosophy behind behind a lot of that kind of therapy. Both, so OT, you know, like I said, Krempels is very OT oriented, but they have some recreation therapy people there as well. And they both draw on the same kind of approaches of helping people refine meaning, right, in their lives after they've suffered a trauma. Let's see. Okay, so we were on class standards talking about, so that it all comes down to, and I hope, you know, hearing Barb talk about, you know, kind of talk about how they approach care, hopefully reinforces what I'm trying to say here is good healthcare is focused on an individual. Now, you may be part of a larger population with some common shared experiences, some common challenges. But at the end of the day, each individual is an individual and they have their own unique needs and desires and challenges that have to be addressed. But but staying with Krempels for one more minute, what did you hear Barb talk about that was like the defining thing that made brain injury a special population? Like what would allow you to like draw a circle around this group of people as sort of a unique population? Yeah.
Because they can't perform like ADLs and basic stuff that they can't feed themselves. They have to go back through the places and start learning all over again.
Yeah, if you have a serious brain injury, like she talked about the founder, David Krempels, serious brain injury, basically had to relearn to speak, relearn to do all the ADLs, right? Relearn to walk. I mean, can you imagine? You just got married and you're on your way to your honeymoon, and then, you know, and now your life is completely, your wife is gone, you know, your occupation is gone. And oh, by the way, you can't communicate, you can't even speak or walk, and maybe you'll never, you know, and waking up in that moment, like, and who am I now, right? So, okay, so, you know, that's a really traumatic, but some people don't have, if you were to go to Krempels, you'd see, not every, and that is what Barb was pointing out, and I probably misspoke, because there are people who are wheelchair bound at Krempels who, you know, maybe can't communicate. So they're at that, you know, also dealing with people with challenges to ADLs. What else? What else would help you set aside people with brain injury from a different population? would make them stand out.
They like had some sort of traumatic event
Mhm.
that led to them ending up in that position,
Okay,
like a chain reaction kind of thing.
okay. So they've had a trauma of some sort. Right. So yeah, so good. So, but it could be an external trauma, like a car accident. It could also be a stroke, right? So one of the key defining things is, as opposed to developmental disability, where you're born with the condition, right? So if you have Down syndrome, you're born with it from day one. You have Down syndrome. So that's developmental disabilities, as opposed to acquired brain injuries. That's what, so developmental disability is like a different social population versus brain injury. They may have some if you drew a Venn diagram, they'd have some overlaps potentially. But they are unique in that they've gone through a trauma. And I think for me, that's one of the really defining elements of brain injury as a special population is you had a life, it was going along, and then it changes due to either an acute illness like a stroke that damages your brain or the result of an accident. And so, people your age, it's more likely going to be the result of a trauma like a car accident. People my age, I'm getting into the stroke range, right? So I could still potentially also have some sort of trauma. So to me, kind of those big things are for defining brain injury as a special population would be, it's acquired in the sense that you had a life of one type, and then you have a break point, and now you have this new life that you have to adjust to. What's the result of that break point? Think of if you went through that experience, how would you respond to it? If I took away your ability to finish your degree, you had to move home to live with your folks for some number of years. You weren't able to go forward.
It can lead to increased like mental stress, and like that on top of also like a brain injury can be really difficult to handle, like more anxiety, more depression, like frustration, things like that. So exactly, right? So when you're looking at acquired brain injury, say, as opposed to developmental disability, right? The people who have acquired brain injury tend to have a lot more anxiety, depression, because they remember, I used to be able to do these things and now I can't, right? And I don't think and maybe I'll never be able to do the things that I used to be able to do. And so that generates a lot of depression, self-harm sometimes, right? And so an important part of organizations like Krempel Center is they help people make that transition to their new lives. I remember I did an interview with Jill Graving, who's the founder of Northeast Passage that I talked about. And she was talking about, like Krempel Center, they take people on in an outpatient setting. So after you've had a traumatic injury, not necessarily, they deal with brain injury, but in this case, the story was an individual guy who'd been in a car accident, I believe, and he lost the use of his legs. And they went to his house to try to engage, and like he'd been discharged from therapy and now he's at home. And they went to the house to engage him, to start trying to work with him to, okay, you've got this injury. It's you are permanently paralyzed from the waist down. Now what? Let's work with you. And she talks about how he was like throwing stuff at them and telling them to get the hell out of his house. And, so there's a lot of anger, a lot of depression, right? Like, there's a happy ending. They eventually work with him, but to help him find, a future. But one of the defining factors of acquired brain injury is the sense of loss. Like they're unified. She mentioned that, Barb mentioned that early in her talk, and I think kind of casually mentioned that. One of the unifying elements of that community is they're all grieving their prior self. Okay, so it's a beautiful organization. Like I said, they do incredible work. Barb has really, she recently stepped down as the director. She retired, and now she's working part-time for the organization as a new director. But her
handprints are all over, what Crimples is today as a result, largely of her leadership. All right, we talked about class, a couple more slides that I wanted to hit. We're almost done. So, I don't know if you guys have done active listening training. Have you? Maybe any of you like an RA? Or, is anyone an RA? No. So like when I was in college, I was an RA. It was the first time I was exposed to this idea of active listening. So you listen to somebody and you say, where did you grow up? Oh, what do well, what was that like? You say, well, I grew up in the, in inner city Boston, and it was, this kind of scary place. And that's it, I'm listening. So what I hear you saying is that you grew up in this, it's kind of a one of the ways you show that you're actively listening is you repeat back. This is what I heard from, you saying, am I understanding what you're trying to communicate to me? You might rephrase it in your own understanding. So that's the idea of, in advance. That's the idea of active listening. Sorry. My slides are not advancing. All right, here we go. So active listening, this idea of actually listening versus just hearing. Like I can talk with my wife sometimes, and she'd be like, "You're not listening to me," and I'm like, and I just repeat back exactly what she just said. But I wasn't actually listening. She was right. I wasn't actually listening. I was able to like process and retain what she was saying, but I was totally thinking about something else. And she was totally right. I'm like, oh yeah, I guess yeah, you did say something that I should have been paying attention to. And so, that's how it is when you've been married a long time. But as a provider, as a good provider will be listening to you and will use those active listening tools to make sure that they actually understand what it is you're trying to communicate. And the key here is that it might not be verbal, right? The things that are being communicated to you might not be verbal. And you need to pay attention to those cues as well. The provider needs to pay attention to those cues as well. Like, oh yeah, I'm fine. I'm fine. Okay, that doesn't sound like you're fine, right? And pay attention to how the person is holding themselves and things like that. But here's the thing: like if you are doing cross-cultural medicine, the way that somebody communicates is going to be based on their culture, and so you have to. It adds a layer of complexity that if you are trying to actively listen to what they're saying, you have to kind of know a person from this culture may say they're fine. But you have to be able to see through that to be, okay, how do I get them to, talk about a challenge that they have? So in the military, for example, there's a huge stigma against mental illness, right? There's a huge stigma against admitting weakness of any sort. And so people come back from combat tours and they have PTSD, right? Post-traumatic stress syndrome. And it is a mental illness, right? But they don't want to admit that they are having trouble sleeping, that they are having stress reactions without an explanation. They don't want to admit that they're weak because much of what they're called on to do and be, and they perceive that they are, that they have to present this powerful, strong front, and so they don't want to admit that they might have a problem. So a lot of military folks, it's really hard to get military people to talk about their challenge and their problems because they perceive that as weak. So in order to get at the problem, you have to work through all of that. You have to find a way that to communicate to a patient like that admitting that you have this problem is not a sign of weakness, right? It is an invisible injury, like what we heard from Barb talking about acquired brain injury, right? You're hurt, you're injured. And if you had been shot in the leg, we'd patch you up and nobody would think the worst of you. But the fact that you were hurt in a different way comes off as weakness. We wouldn't look at somebody who'd been shot in the leg as weak, right? We'd look at them as injured. And so the right attitude towards that is to look at an injury. And so again, like I've talked about, culture isn't just about race and ethnicity. It is also about your experiences and your beliefs in the world. And so that's another example. This idea of patient-centered care is a common one you're going to hear about. Patient-centered care, the idea that care should rotate around the individual and the individual's needs and wants and beliefs. And this sounds completely common sense to us, except that that's not the model that medicine ran on until relatively recently. Like, this is a revolution in the last 20 years of saying like, hey, you know what, we should like listen to the patient and see what the patient really wants to do. Because I told you, I've mentioned my father was a physician, and I've talked with him about this and about his training back in the 70s. And when he went through medical school and through his medical training, he was told that a good physician diagnoses the patient and then convinces the patient to take the right treatment. And then it was up to the physician to decide what the right treatment was. That's very much a disease model, right? We talk about illness versus disease. That's very much an attitude of, I'm the physician, I know what you need. And to not really listen to what is the patient really want. There's a great book, he's an interesting doctor. He's a general surgeon out of Harvard Medical School, and I think Mass Gen, and wrote a book. What's escaping me? His name is Atul Gawande. Anybody read it? Any Atul Gawande work? Okay. Recommended. I'm blanking on the name of the book, but he talks a lot about talking to his patients and saying, all right, you have colon cancer, you have stage 4 colon cancer. You have, depending on what we do, you have somewhere between 3 months and maybe a year to live. Here are the treatments that I can give you that would extend your life to a year. I might have to remove most of your colon, and you have a colostomy bag, which is a way of expelling your waste into a bag. We could do that surgery. We could do chemo, but that's going to be debilitating to you. So you're going to probably be wheelchair bound if we do that. You'll live longer, but these are the side effects of the things that I'm offering to do. You want to do that, or would you rather have a shorter period of life where you have greater mobility for a portion of that remaining time? So he tells a story about he's having this conversation with I think it was a man whose daughter was going to be getting married, and so the man's main concern was getting to the daughter's wedding, and so he had to make choices and he wanted to be able to dance with his daughter, so he chose not to take the greater interventions that would have put him into a wheelchair and so forth, but that meant that he was going to live a shorter life. And I would tell you that that's a new model, that idea of like presenting the patient with, these are your choices and these are the impacts. How does that meet the things that you want to accomplish in the time you have left? Right? In this case, assuming it's a terminal illness. Much like what Barb talked about, like we're going to meet with you and talk about what is it you want to do. Now that you have an acquired brain injury and you can't be the person you were, what is it that would be important to you kind of going forward? What would give you meaning and fulfillment and a sense of health? So this idea of patient-centered care is very different. So going back to like my father's training, he would have been like, no, you need to get the chemo and you need to have the colon surgery. And you just can't dance to your daughter's wedding. It's just how it's going to be. And so that was an older model of the doctor knows, and the doctor-centric care as opposed to patient-centered care. So this is kind of the idea of patient-centered, patient in the middle, right? And different values that go around it. And ways that we try to address that. I will tell you, I'm a terrible patient, right? I'm a bad patient. And the part of the reason I'm a bad patient is because I grew up literally with a doctor as a father. So so he dealt with most of my, illnesses and diseases by basically telling me to tough it out. Like one time when I was 8th grade, I was going down to my friend's house. I had a book bag on my bike and I was riding my bike and I was holding the book bag on the front handlebar. You see where the story is going? Book bag turns sideways, goes into the spikes. I go over like that, right? And fractured my clavicle, right? So I'm like dragging I had to walk like this and carry my bike because I had broken, like the front wheel was all mangled. So I'm walking like this, carrying my bike home, luckily I hadn't gone that far. And then I call my mother and, and she calls my dad who's, at work. And I think eventually he comes home and he looks at me, he's like, well, there's nothing you can, you've got a broken clavicle. There's nothing you can do other than put it in a sling. Like there's nothing to do. And I'm like, but I need to go to the hospital. He's like, you don't need to go to the hospital. There's nothing you can do. Take some aspirin. Shut up. So that's kind of what I grew up with there. And then I went into the military and I worked in healthcare. And what was cool about that was, as a healthcare administrator, I knew all the doctors in the organization. So like, if I had an issue, I just walked down the hall like, hey, Bob, I hurt my arm the other day. He'd be like, oh, I'll order an X-ray, or I got a little cough. I'll just I'll take care of it, whatever. So I knew all these doctors. I knew all the doctors, like as in my professional role. So I knew them all. So I trusted them. Now I don't have that. Like my provider is just this random. She's very nice, but she's just random nurse practitioner. I don't know anything about her. I don't know if she's got kids. I don't know. I don't know what her work ethic is like. I don't know if the nurses think she's good or not, because that's one of the best things. If you can talk to a nurse, ask a nurse, which doctor would you go to? That's the best way to do that. So I'm a terrible patient because I'll go in there and I'll just start talking, and I know I'm like watching the clock, and I know I'm using up the time because I don't trust you. Like I don't know you. Like I don't know anything about you. I want to know, So I'm a lousy patient in that way. And if I don't trust you, then I'm not going to do what you tell me to do. Right. So in a way, I'm a special maybe I'm a special population of one, because but the challenges of healthcare are, you've got to find a way to get your provider, the provider has to find a way to create trust. So last slide, we've been talking about special populations, but people aren't populations. People are individuals, right? First and foremost, they're individuals. Now they may have overlapping identities. I'm a brain injury survivor. I'm a cancer survivor, right? I'm a woman. I am a racial minority, right? All these things may overlap, but still at the end of the day, a person is a person. You have to talk to that person and understand what their concerns are. So a good healthcare system and good providers are aware of the cultural components of special populations and the way that those special populations communicate, and kind of some of their uniquenesses, but at the same time balancing that with the fact that there's an individual sitting in front of you that needs your care. All right, so we'll see you. Have a good weekend. Is today Thursday? Yeah, have a good weekend. And hey, some of you are doing the talk with Eileen Keefe today. We're going to do that at 1. So I'll see you on Zoom then.
I actually had a question about the extra credit.
Yes, ma'am.